Hello and welcome to this podcast in our series on evidence-based medicine on diagnostic testing. I'm Rashmi Patel, and in this podcast I'm going to go through some of the key principles of why we do laboratory investigations and how you can assess the quality of an individual test, and also some of the pitfalls you can encounter when interpreting the results of laboratory investigations. So first of all, why do we as clinicians perform laboratory tests? Well, the main reason why is to try and improve our diagnostic accuracy. So you may have an idea from taking a history and examination about the possible diagnoses the patient might have, and then you may want to perform a certain series of investigations to see whether your diagnosis is correct. So the purpose of the investigation would be to try and improve the validity of your pre-test probability based on your clinical judgment, to give you a higher post-test probability based on the results of the investigation. So how do you go about assessing the quality of a test? Well, I think that two of the main features that a good diagnostic test should have is that it should produce a positive result in all patients with the disease and a negative result in all patients without the disease, and that seems like common sense. But of course, in reality, there is no laboratory investigation you can perform which will give you with 100% certainty that all patients with the disease will have a positive test and vice versa. So how do you go about assessing how good a test is based on these criteria? Well, there are a few parameters you can look at when examining the quality of a diagnostic test. One of these is to look at the specificity and sensitivity. Now, the specificity of a test represents the proportion of patients who do not have the disease who have a negative result on the diagnostic test you're looking at. So in other words, a proportion of true negatives. And so a test with a high specificity will help you rule in the diagnosis if the result is positive. And one way to remember this is with the acronym SPIN. So SP for specificity, high specificity, helps rule in a diagnosis. In contrary to that is the concept of sensitivity. And that is, in contrast, a proportion of patients with the disease who have a positive test. So in other words, the proportion of true positives, and a test with a high sensitivity will help rule out the diagnosis if the test result is negative. And one way of remembering this is with the acronym SNOUT. So SN for high sensitivity will help you rule out the diagnosis. So why don't we actually have a look at this in further detail? So this table looks a little bit complicated, but I'll just take you through it. And it just illustrates the parameters you're looking at when you're performing a diagnostic investigation. So in the columns, you have the number of patients with the disease and the number without the disease. And then along the rows, the number of patients who test positive and the number of patients who test negative when you perform your diagnostic test, and then the totals added up across the columns and the rows here. So the sensitivity you work out by looking at the columns. So here we go. This is the proportion of true positives, A over A plus C. And then here, if we look at this column, D over B plus a D will give you the proportion of true negatives for the specificity. So why don't we look at this in a worked example? And this is some data taken from a journal article published in Annals on the use of D-dimers in helping to rule in or rule out the diagnosis of PE. So here we have a table with the numbers representing the number of each patients in each group. And if you were to work out the sensitivity and specificity, you can see here they've been calculated here. The sensitivity of D-dimer for establishing the diagnosis of PE is 85%, whereas the specificity is slightly lower at 68%. Well, what does this tell us? Well, it tells us that the D-dimer test is slightly better at helping to rule out the diagnosis than to rule it in, because it has a higher sensitivity than a specificity. Now, another useful parameter in assessing diagnostic tests is that of the predictive value. This is related in a way to looking at sensitivity and specificity, but perhaps more useful conceptually, because as a clinician, what you really want to know about a diagnostic test is how many of your patients who have a positive test are likely to have the disease. So that would be the positive predictive value, and in contrast, the negative predictive value, patients who have a negative test, what proportion of those do not have the disease. So let's come back to our table now and have a look at this. So the predictive value in this case is now looking at the rows. So we're concerned with the test result here. So for example, we want to know the proportion of patients with a positive test, that would be A, who have the disease. So that's A over A plus B, the positive predictive value. And in contrast, it would also be helpful to know patients who test negative, who don't have the disease. So that's a D over the total who test negative, C plus D, and that would give you the negative predictive value. And now if we come back to this data on the D-dimer, you can see now that this gives us some quite helpful information, that if you now calculate the negative predictive value of the D-dimer test, you can see it's actually very high at 95%. And so what we can say is that on the basis of these results, if a patient has a D-dimer test, then they're very unlikely to have a PE. Whereas in contrast, the positive predictive value isn't so good. So the number of patients who have a positive D-dimer, the proportion of those who actually have a PE, isn't that high. So again, we can say that D-dimer is probably a better investigation at telling us that patients do not have a PE. And finally, moving on to the concept of the likelihood ratio. What this looks at is the ratio between the probability of a test result occurring in a patient with the disease compared to a patient without the disease. And if we break that down a little bit, we can consider the positive likelihood ratio and the negative likelihood ratio. This helps tell you how the result impacts on the post-test probability compared with the pre-test probability. And generally speaking, the further away the likelihood ratio is from 1, the more likely that the diagnostic test is associated either with the presence or the absence of disease. And a good diagnostic test, if you're looking for a test which will help you with the diagnosis, will have a positive likelihood ratio of over 5. And a good diagnostic test to tell you that to try and refute the diagnosis will ideally have a ratio of less than 0.2, or in other words, 1 over 5, a fifth. So if we have a look at our data again, how do you calculate these values? Well, it's very easy. You look at, for the positive ratio, 1 minus the sensitivity over the specificity, and for the negative ratio, the sensitivity over 1 minus the specificity. And now coming back to our data on PE, now I have to apologize here, there's a slight mistake in the slide. the negative and positive is the wrong way around here. So in fact, this top value here should be the negative likelihood ratio, and the bottom value here should be the positive likelihood ratio. So my apologies. So let's just focus on the numbers here. So this is the calculated negative likelihood ratio, 0.2. And that's a pretty good value. It's quite close to 0.2, and so that tells us that the D-dimer is pretty good at telling us that the test result, if negative, is associated with the absence of the disease. Whereas in contrast, 2.65, the positive likelihood ratio, well, that's still sort of quite close to 1. So the test probably isn't that good at telling us if a patient has a positive result, that it is associated with having the disease, in this case PE. So now moving on to discuss about some of the pitfalls you can encounter when using diagnostic tests and laboratory investigations in practice. You can break down some of the errors which can occur, analytical errors, when interpreting diagnostic investigations into a systematic way, looking at pre-analytical errors, analytical and post-analytical errors. And when I say analytical refers to the process of actually doing the test, and pre obviously occurs before doing the test and post occurs afterwards. So pre-analytical tests, and these mostly relate to processes which occur with the patient before whatever sample is sent off to the laboratory. So some of these issues may include incorrect labeling, so you've taken the sample from the right patient but with the wrong label, or you've printed out a label for your sample container but taken the sample from the wrong patient. And of course these can be very critical errors in areas such as blood transfusion. Another issue is that of actually taking the wrong sample. So for example, if you're looking at a test which requires urine rather than a blood test, and you send the wrong type of sample, or for example if the sample is contaminated in some way, for example a microbiological sample, blood culture being contaminated with skin flora, or if you're doing a blood gas and you get a mixed arterial venous sample, or you're doing a lumbar puncture and you have bloodstained CSF. Another issue could be taking the sample at the wrong time. So for example, the wrong time of day, or not taking a sample when it should be fasting if you're testing for glucose. Or if you collect the sample in the wrong way, in the wrong container, if you use the wrong vacutainer for your sample. For example, if you were to use potassium EDTA purple top tube for biochemistry, you may end up discovering your patient is hyperkalemic because of the potassium in the tube. Or if you contaminate your sample with heparin from a lithium heparin bottle for a coagulation screen, you might have abnormal coagulation result. And finally, the sample may be handled incorrectly on its way to the lab. So it might be a sample which requires rapid analysis and it doesn't reach the lab on time, which could result in problems, for example, hemolyzed samples giving spurious potassium results. So those few examples of pre-analytical. What about analytical? Well, these refer to the processes which occur with the sample during the particular test. And these are mostly related to the process of doing the diagnostic test. And this might be things like preparing the sample, spinning down the blood, freezing it or diluting it to the right level, or the equipment calibration. And there's a couple of concepts here. First is precision. And what that tells you is if you were to repeat a sample, same sample several times with your machine, would it consistently produce the same results? And the bias, which tells you whether the actual result is accurate, is in the right range of accuracy. And then you can have problems with reagents, wrong concentration or expired reagents. And then problems in between samples, carry over. So for example, you might have a a specimen with a very high concentration of a particular analyte you're looking at, and that could contaminate subsequent samples being analysed. And finally, errors which occur after the test has been performed, post-analytical. So these might, for example, include in the laboratory having got the result for the sample, but then attributing it to the wrong patient on the computer system. Or if you're a doctor on the ward, you might look at a result and actually be looking at the wrong patient set of results. So you make a diagnostic decision based on what you think is the right result, but on the wrong patient. Or you may look at a result which is from a test which is not taken at the right date or time, the previous test. You might interpret the test using the wrong units, if it's a numerical test. Or you may fail to correctly interpret the test in the context of the clinical situation in which it's being used. And that's going back to some of the issues we were considering previously, sensitivity and specificity. So in summary, in this podcast I've covered an overview of why as clinicians we use laboratory tests, and ways in which you can help assess the quality of an investigation and see if actually a test is going to be useful in a particular clinical setting to help establish or refute a diagnosis. And we looked at some concepts like the sensitivity, specificity, predictive value and likelihood ratio for that. And finally, some of the pitfalls which you can encounter when interpreting the results of a test, and these can be broken down into pre-analytical, analytical and post-analytical. So I hope you found this summary of diagnostic testing and interpreting diagnostic tests useful. Thank you for listening, and please do visit our website for more podcasts in our series on evidence-based medicine. Thank you very much.